Thank you, Professor Saxena, and I want to thank everyone who organized this meeting, especially Dr. Diman for inviting me. I know it is a very difficult task to follow, Dr. Serene, and I will try my best to justify my invitation or your invitation. So when you look at the alcoholic hepatitis or alcohol-related mortality around the world, we're not going to make any impact based on liver transplant. At least 100,000 people die in US every year from alcohol-related disease. And 30% of all liver-related deaths in Europe and North America could be attributed to alcohol. So what is early liver transplant? And that is a definition which we have no consensus, but most centers would say the alcohol abstinence should be less than 6 months. That's by convention. There is no hard and fast rule. So the question is, why early liver transplant? Majority with severe alcoholic hepatitis, I define that by MADRS function more than 60 perhaps, and they will die within 3 months if they do not respond to steroids. There are various prediction models, but positive prediction value of those models are suboptimal, 20 to 44% with almost all models. Negative predictive value is very good. But if these patients present with ACLF3, the mortality could be as high as 90% in 30 days. So this study, many of you have seen this, made a major difference in the way we looked at liver transplantation in alcoholic hepatitis. It's a small study from a French-Belgian group published in New England Journal, which gave it a lot of notoriety. 26 patients were listed for transplant. That's only 2% of all the patients they had seen during that period. They were selected by consensus. And they showed that 6-month survival was excellent, 77%. And those who were not transplanted, the mortality was almost 80%. And only 3 people started drinking in that small subgroup of patients. After that, there was an increased interest in liver transplantation for alcoholic hepatitis in the United States. As of 2017, almost 50 centers were offering liver transplant for alcoholic hepatitis. And the number of transplants, at least listed in the UNOS, increased significantly over that period. And those patients had excellent 1-year graft survival. So the question we were asking, at least my own anecdotal experience and experience with the transplant centers around the country, the number of patients listed in the UNOS as alcoholic hepatitis does not really represent the true number of patients transplanted around the country. This was a study, they looked at retrospectively 124 patients as a part of a consortium. And they had granular data they could look at. And the 124 patients they thought had alcoholic hepatitis and they transplanted. But only 43 of these patients were listed in the UNOS as alcoholic hepatitis. A variety of reasons. The coding person did know that there was a specific code for alcoholic hepatitis. And some of them, or many of them, had alcoholic cirrhosis in addition to alcoholic hepatitis. So this really is my own experience from working in this field, that many patients with alcoholic hepatitis are not listed as alcoholic hepatitis, and they are transplanted because they have a higher MEL score. So recently we looked at the UNOS data. When you look at the number of people listed for alcoholic liver disease, it's increasing significantly. And it's almost 4,000 patients are listed. And the patients with alcoholic liver disease and hepatitis C, both, that is declining as to be expected because of hepatitis C cure. And alcoholic hepatitis slowly increasing. So we just thought, maybe many of these patients with alcoholic liver disease are coming or presenting as ACLF. So we looked at the data in a different way and say the number of patients with ACLF3 transplanted within 28 days after listing. That is 28 days after listing. 40% of those patients had alcohol as the diagnosis, suggesting that we are not really reporting the true number of alcoholic hepatitis in this country. And there is evidence, and not confirmed, that alcohol is the precipitating event for ACLF in 25 to 60% of patients in North America as well as Europe. And most of these are unrecognized. So we thought we could make an estimate of the number of alcoholic hepatitis transplanted in the US. We just used a cutoff as bilirubin more than 12 milligram at the time of listing and alcoholic liver disease as a primary diagnosis. So when you look at this, there is a significant number of patients, almost 15% of liver transplant done in the United States, probably, I could say only probably, may have alcoholic hepatitis with or without cirrhosis. When you look at their MEL score, we cannot calculate MDF from UNOS because they don't give you prothrombin time. So we had to use a sort of control arbitrarily. But it represents what we think is alcoholic hepatitis. Very high MEL score, very high MDF. And when you look at discriminant function more than 60, 90% of these patients had probable alcoholic hepatitis. That will be about 8,000 patients transplanted over a period of 18 years, which is 15% of all transplant. As expected, when you look at this, on the left-hand panel is those who are listed as alcoholic hepatitis. On the right-hand panel, those who are probable alcoholic hepatitis. You can see if you are not transplanted, very high mortality. In the probable, almost 70% died within the first 3 months. This is similar to what others have published too. So one of the questions we were asking is, if the mortality is 70% in the first few weeks, should we be transplanting them earlier on, before they even have a steroid trial, or should we transplanting only those who have a allele score which are higher? So when we looked at the patients who were listed by days within listing, and really didn't make any difference. As long as they got transplant, they all did very well. The early transplant didn't matter. But another way of looking at it is, we looked at 30 days, 90 days, and 1 year survival. The timing of transplant didn't really matter. But majority of these patients had organ failure. Interestingly, unlike other ACLF studies, in this group, the hepatic encephalopathy is a bit lower. The brain failure is much lower than other ACLF studies. That is to be expected. These are younger population, and many of these alcoholic hepatitis often do not present with hepatic encephalopathy. And we looked at a multivariable model and we put transplant as a variable in that. So whether it is listed as alcoholic hepatitis or probable, not transplanting has a hazard of 44 times or 36 times in the listed. And other variables were age, MELD, and hepatic encephalopathy, interestingly, is a significant predictor of mortality in the multivariable model, indicating that in people with alcoholic hepatitis, if they develop encephalopathy, that is a bad prognostic predictor. None of these things were a surprise. Only thing I was a bit surprised that encephalopathy came out as an independent predictor in this model. Most of the other studies with ACLF do not show that. So we just looked at the patients with alcoholic hepatitis versus alcoholic hepatitis alcoholic liver disease. And you can see alcoholic liver disease had a better outcome than alcoholic hepatitis, whether in the listed or by predicted models. So that is to be expected, about 10 to 20% lower survival in alcoholic hepatitis, mostly maybe because of ACLF3. So we just looked at them by ACLF3. When you look at ACLF3, they have a lower survival in the left-hand panel, the listed or the probable, by almost 20%. So you may expect in majority of these patients with alcoholic hepatitis with ACLF3 have with a lower survival than those without ACLF3. But when you compare ACLF3 with alcoholic hepatitis compared to alcoholic liver disease, they're identical. So it is the ACLF3 which is probably causing them to have a lower survival. So what did we learn from this? We don't have to debate whether they have a good outcome. They have excellent outcome. And it is the liver transplant is the most important predictor of survival. Early liver transplant, the timing is not important, but early liver transplant will reduce the overall mortality, as you saw. Most of them die within 90 days. And transplant current studies are mostly retrospective, just as our study, and is based on selected patients. So the question we would ask is, should we transplant everyone? Or on moral or ethical reason, we should deny them liver transplantation? I'm not going to address that, but let me give you some data. Whichever way you look at it, and meta-analysis and many other studies show that less than 6 months of abstinence is associated with less recidivism. And other factors are lack of insight about alcoholism, poor social support, failed rehab attempts, younger age women, family history of alcoholism, underage children, and other substance use. And this was a study published in 2018. Again, a retrospective study, a consortium of 10 hospitals looked at their data on alcoholic hepatitis, and the cumulative rate of alcohol use in this was 34% at 3 years, 25% at 1 year. And those who drank early, their survival was 75% compared to 100% in those who remain abstinent. So again, showing that alcoholism will reduce, or recidivism will reduce their graft survival. And this has been shown in other studies too. This is not published yet. This was presented as an abstract at the AASLD in 2020. They were looking at prospectively whether 2-year alcohol relapse will be different in those who were transplanted early compared to the alcoholic cirrhosis who have abstained for more than 6 months. There was no difference, and sample size was not big, but in the alcoholic group versus cirrhosis, there was no difference in survival. If they were not transplanted, as they're shown in their New England Journal paper, mortality was significantly higher. But the take-home message from this was 33.8% of early transplant started drinking again. More importantly, heavy drinking was higher in that group, 22%. So 1 in 5 started drinking quite heavily, even in a prospective study like this where they were carefully controlled. So take-home message is patients with severe alcoholic hepatitis should be selected very carefully. This is one of the studies published in December in gastroenterology from Canada. They had a large cohort of patients from which they selected 164 patients for possible liver transplant. They had 730 patients referred during that period. Of that, they transplanted 44. They had an integrated addiction treatment program, and they found that only 3 of the 44 drank after liver transplant, and they had excellent outcome, suggesting that if you're going to transplant, we need to have a treatment strategy. Those who are alcoholics, they're more likely to drink if they didn't go through an integrated program, which may need to include a psychiatrist treating their underlying depression if there is. So in conclusion, we can say that alcoholic hepatitis, if they are transplanted, they will have a very good outcome. And whether they are live donor or a deceased donor, it probably doesn't matter. If the person does not respond to steroid, and if the Lille score are high, the best outcome treatment for them is liver transplant if it is feasible. And is the single most important predictor of survival. And 20 to 30% will drink heavily after liver transplant if they're not abstinent for 6 months or more before transplant. If you're going to use less than that, you need to involve them in an integrated treatment plan for addiction. Liver transplant is an art for alcoholic hepatitis. I don't think it is a science yet. Whatever models we use, you as a clinician will have to decide whether the patient is the right candidate for liver transplant, because one of the most important things I have found is the lack of insight of many of these patients, which make it very difficult for them to abstain from alcohol later on. And there is a collateral damage. We don't want to talk about it much, because when we transplant them with a deceased donor, we are denying another person a liver transplant. So that is the collateral damage. It is very difficult to quantify that because there are multiple factors that are involved in the transplant decision process. Thank you.